on my research focused on hospice care for people with dementia. Okay. So my intention for today is really to provide a broad overview of hospice care for people with dementia and highlight some of the major issues in this space and talk about some of the work myself and some of my colleagues have undertaken to understand these issues better. To do this, first, I'll give some background on dementia at end of life among U.S. decedents. Then I will briefly give some background on hospice, the history and trends in hospice, specifically focused on Medicare hospice benefits. Then I will provide an overview of hospice use patterns in dementia, the good, the bad, and the ugly. And then finally, I'll discuss some key takeaways on the role of hospice in dementia. All right, so I don't think I need to tell this group that dementia is a major public health issue in the United States today and globally. With the aging of the population, the number of people with dementia is rising rapidly, and we're expecting to see almost 15 million people with dementia by the middle of this century. I think one thing that is less well recognized is the impact of dementia at end of life. So Alzheimer's disease and related dementias are terminal illnesses, and Alzheimer's disease is the only major cause of death where the death rate has increased in recent years. You can see in this figure that the death rate from Alzheimer's disease has risen dramatically since the early 80s, while all other major causes of death like heart disease and cancer have actually declined over the same period. So even when dementia is not the official cause of death on the death certificate, it's still often present among older adult decedents as a comorbidity. So it's estimated that 1 in 3 older adults die with or from dementia in the US, 1 in 3. And even if dementia is a comorbidity at time of death and not necessarily the cause of death, it's still having major impacts on the experience of the person and their families because of its effects on the person's cognition, their ability to communicate or function, etc. There are other characteristics of the dementia trajectory that have really important implications for end of life and hospice care that we're going to be talking about later. So the typical conceptualization of dementia is that it's characterized by a slow, long, dwindling decline in function, although I'm actually working on another project I won't be talking about today where we're looking at functional trajectories after disruptive events like hip fracture and pneumonia and finding accelerated declines in function. The other feature of dementia is that it's really difficult to prognosticate. So this is data from a study by Susan Mitchell and team where they tried to create a prognostic tool to estimate 6-month mortality in advanced dementia. And basically what they found was that this tool was only this really super smart group of investigators could make a tool that was only slightly better than flipping a coin at estimating when people with dementia would die. So our knowledge about the end-of-life experience for people with dementia is pretty limited, but we're starting to get a sense of what this experience is like for people with dementia and their families. And what the literature is showing is that the last months and years of life in dementia are really very challenging experience for many patients and families. It's expensive, it's hard on caregivers, and it's difficult to navigate. This is a study that was led by Amy Kelly, who was formerly of Mount Sinai and is currently the deputy director at NIA, where she examined costs of care for people with dementia in their last 5 years of life. And as you can see in this figure, spending for people with dementia, total spending was about 30% higher compared to those without dementia. And particularly the costs for informal care and out-of-pocket costs. So in this study, they looked at caregiving strain in caregivers of people with and without dementia, both not at the end of life and at the end of in the last year of life. And as you can see in this figure, caregiving strain was not surprisingly much higher for caregivers of people with dementia, but particularly it was higher in the last year of the person with dementia's life. So people with dementia might not always be able to die in their location of choice. Most people say they want to die at home, but for people with dementia, this only happens for about a third of people. We also see differences in the location of death by race and ethnicity. So white people are much more likely to die in a nursing home, while Black and Hispanic people with dementia are more likely to die in the hospital setting. And this might reflect preferences around treatments at end of life, but also may reflect lack of access to adequate care that would allow people to die at home. I did this work with Inbal Mayan, who was a GBHI fellow here at UCSF, and I believe is now associated with your ADRC. People with dementia and their caregivers often don't feel supported by their doctors and other providers and the healthcare system in general. So this is a quotation from one of our participants in a mixed method study I worked on with Jarmania here at UCSF, where we asked caregivers of people with dementia about their end-of-life experience. And this was one person's response. I believe the doctors are checked out. There seems to be no connection between their work and the day-to-day decisions and care that needs to be done for a patient with dementia. A more interconnected approach between doctors and the front offices, nurses, hospice workers, labs, social workers, and caregivers seems necessary. We all face this. Why is there not a better system in place as patients move from one stage to the next? And I just felt like this quote was very illustrative around the kind of trauma that people can experience during this period. Every caregiver should be sat down and end of life should be explained. I was not ready. I had no plan. I didn't even know what hospice was, practically speaking. I know the word and its definition, but I didn't know how it worked. I did not know or see a list of things you need to do for someone dying at home. I missed the moment of death because I was answering the door for an oxygen delivery. It was absolutely the worst experience of my life. Not my mother's death because she was suffering, but the mental trauma was significant, and I still haven't recovered. Now, I don't want to paint the picture that end-of-life experience is always negative. On the other hand, there can actually be some really positive experiences for people with dementia and their caregivers at end of life. So this is a quote from a caregiver in a study that's currently in progress, who said, when he was getting bad and couldn't converse with me a whole lot, he would squeeze my hand. I'd ask him if he wanted me to sing for him. He would close the door because I was a horrible singer. The last one he could remember was Home on the Range. He was a cowboy type rancher. I sang to him until he might have heard me. I don't know. As long as he could squeeze my hand, I would sing to him. He liked music. That was one thing we could share. Okay, so now I'm going to shift gears a little bit and give some background on hospice in the US and the Medicare hospice benefit. And to do that, we need to go back to everyone's favorite decade, the 1980s. Remember, some of you may remember, some of you may not. So hospice in the US started as a social movement Okay. Hospice in the US started as a social movement in the late 70s and was led by Florence Wald and other oncology nurses who were really disenchanted by the medical model that emphasized disease treatments at all costs. The hospice model, as they envisioned it, on the other hand, emphasized support and pain and symptom management for people with serious illness. So there were some early demonstration projects in the 1980s for cancer patients who showed improved pain and symptom management and reduced costs. These early studies showed that the cost of care was very sensitive to length of stay. So at the time, the Medicare hospice benefit legislation was being created in the early 80s, there was a lot of concerns around healthcare spending at the time. So there were a number of measures put in place in the hospice benefit to ensure budget neutrality, including a per diem reimbursement model, requirement that enrollees had an expected prognosis of less than 6 months if the disease ran its normal trajectory. Enrollees were required to agree to forego traditional medical services. Initially did not allow nursing home residents, and total hospice days was capped at 210 days of 2 90-day periods and 1 30-day period. There's also an aggregate cap put on of a per patient per year average amount that hospices could receive, and that was really designed to be a limit on the length of stay for patients. So following the implementation of the Medicare hospice benefit, there was legislation in the later 80s that expanded access to include nursing home residents, and also recognizing that prognostication is often difficult and that cutting people off at hospice at 200 days would potentially deprive them of needed services. The cap on days was dropped, and instead enrollees could have an unlimited number of 60-day benefit periods if they still continue to qualify for the benefit. So these changes had a really big impact on the growth of hospice. Between 1990 and 2000, there was a tripling in the number of hospices, which then doubled again in 2000 to 2010 and is continuing to increase. There was a big increase in large for-profit corporately owned chain hospices. And for hospices that are interested in maximizing their profit margins, the most effective business model to achieve this is to try and enroll long-stay, low-need patients, such as people with dementia. So this figure just shows the increase in number of hospice providers since the year 2000. You can see that the number of hospices has almost quadrupled, and this is largely driven by an increase in for-profit hospices. And this figure shows the increase in annual hospice expenditures from $2 billion a year in 2000 to over $20 billion in the year 2020. Another trend that we've been seeing recently is the entry of private equity into the hospice market. So this is from a study done by Braun et al. Showing the number of Medicare hospice beneficiaries who received care from a hospice owned by a private equity company. And people are really concerned about private equity in hospice because private equity is an investment model that is very focused on turning around big profits in a short period of time, 3 to 5 years. And this raises concerns about the quality of care that's being provided for those patients, and creates a lot of cognitive dissonance for people when you're thinking about dying patients who are at their most vulnerable. Some of you might have seen this New Yorker article that came out last December that delved into a lot of these concerns that have arisen over the hospice industry in the last several decades, and looks at issues around Medicare fraud, poor quality of care for patients, and has some really compelling stories about the experiences of hospice whistleblowers and patients. Medicare has implemented a number of policies that were designed to address some of these concerns around long length of stay and questionable and perhaps even fraudulent enrollment of people into hospice who were not actually terminally ill. These policies and regulations included increased audits, quality reporting, changes to allowable codes, and in 2016, the first change to Medicare hospice reimbursement since its inception, where instead of a single per diem reimbursement rate, they moved to a two-tiered structure with higher payments for the first 60 days and then decreased payments after that. All right. So now I'm going to move into talking more specifically about hospice for people with dementia. So we've been talking a lot about how dementia is more prevalent at end of life. There's uncertainty around prognosis. People look like they might be hospice eligible, but then might actually live for a long time. I've talked about how there's been big growth in hospice use and number of agencies and expenditures, and how hospices profit off of patients who tend to have long stays given the reimbursement structure. And so, not surprisingly, what we see is a big increase in dementia patients over the past 20 years. So this is some work I did with Melissa Aldridge from Mount Sinai, where we estimated how many people in hospice have dementia, including those who were admitted to hospice with dementia as their qualifying terminal illness, as well as those who were admitted for another condition but had comorbid dementia diagnosis. And basically what we found was that 20% of hospice enrollees are admitted for dementia, and another 25% are admitted with dementia as a coexisting diagnosis. So almost half of all hospice enrollees have dementia. So there's been, not only has there been a really big increase in the total number of patients in hospice since the year 2000, but a lot of this is due to the growth of dementia in hospice. So in this study, we also looked at hospice use patterns, and we found that the patterns look really different for people with dementia compared to those without dementia. So in this figure, the people with primary diagnosis of dementia are shaded in gray, and comorbid dementia is in orange, and no dementia is in blue. And so you can see here that people with dementia, both with primary and comorbid dementia diagnosis, are much more likely to be enrolled in hospice for longer than 6 months. This is on the right side of the figure, and are less likely to be enrolled for less than 3 days. We also found that people with dementia are more likely to be disenrolled from hospice. This is also sometimes called live discharge. So almost 1 in 4 people with a primary diagnosis of dementia are discharged from hospice before they die. You see this on the left side of the figure over here. So slightly lower for people with a comorbid diagnosis, and much lower for those with no dementia. And for people with dementia, these disenrollments are much more likely to occur after long lengths of stay compared to people with no dementia. So disenrollment after long stays is usually because the person no longer meets prognostic eligibility criteria. So in the beginning, I talked about how in order to be eligible for hospice, you need to have a likely prognosis of less than 6 months, but you can be recertified and continue to have hospice for an unlimited number of 60-day periods. But you need to show evidence of continued decline in order to be recertified. So if your condition stabilizes or improves, then you no longer meet hospice eligibility criteria and will have to be discharged. So sometimes people call disenrollment from hospice due to disqualification or extended prognosis graduating, quote unquote, graduating from hospice. But I refer to it as getting expelled from hospice because the research shows that disenrollment is bad for people with dementia. It disrupts care continuity and the relationships that people have developed with their hospice providers. And there's really no other services available that provide a similar level of comprehensive and holistic care that hospice does. This is a quote from a caregiver who was discharged from hospice, but what that experience was like for her. So as of tomorrow, no CNA, no medical equipment, no medicines, no nurses checking him out. We have to re-engage with all his physicians, go to their offices to get them reacquainted with his new symptoms, get new prescriptions for meds, obtain new durable medical equipment, fight with insurance coverage, et cetera, et cetera. So we've also found a lot of variation in care provided in hospice for people with dementia. This data is from a study we did using 100% Medicare claims, where we looked at agency, hospice agency, and geographic variation in disenrollment for people with dementia. And we found that there was a lot of hospice agency variation in disenrollment. So this figure on the left is a caterpillar plot where we show the predicted disenrollment rate for each of the 4,000 plus hospices in the United States. And you can see here there was quite a wide range. And basically the take-home message from this is that which hospice a person receives care from doubled their likelihood of disenrollment on average, regardless of any of their patient characteristics. We also found geographic variation. You can see in this map here on the right, and particular hotspots of high disenrollment rates in Southern California and the Southeast US, which are areas that have been concerns around clustering of bad actors have been centered. We've also found that there are racial and ethnic disparities in access to high quality hospices and outcomes within those hospices. So in this study, we looked at racial disparities in disenrollment by hospice agency quality. And we used publicly available hospice care compare data to obtain quality ratings of the hospices. We then sorted those hospices into quartiles and examined disenrollment stratified by race and ethnicity using our 100% Medicare claims data. And we found that all patients, regardless of race, in the lower quality hospices have higher rates of disenrollment. But we also found that racial disparities persist across all categories of hospice quality. So even in the highly rated hospices, racial and ethnic minoritized groups had higher rates of disenrollment. Another interesting finding from the study was that there were many hospices, about 1/3 of all the hospice agencies did not have a quality score reported because they did not meet quality reporting requirements. And we found that the disenrollment rates for those hospices were much higher than any of the hospices that did have a quality rating, which raises concerns that there are hospices that are flying under the radar of our ability to assess their quality and how that has impacts on patient care. So on the other hand, in work led by Krista Harrison, we showed that hospice was associated with better outcomes for people with dementia at end of life. In this study, we used data from the National Health and Aging Trend Study, a nationally representative survey, and they interviewed bereaved caregivers about the experiences of the participants in the last month of life. So people with dementia who received hospice had higher proportions of rating their care as excellent, more often had their anxiety and sadness managed, and were less likely to have a late transition. Also, in work led by Melissa Aldridge, we found that hospice enrollment for people with dementia reduces total costs, including for Medicare, Medicaid, out-of-pocket, et cetera. For community dwelling people with dementia, up to a year of enrollment in hospice. A lot of this savings was driven by reductions in inpatient care. It was notable in the study that cost savings were less substantial for nursing home residents. So there's been some work that's been starting to look at impacts of Medicare policies on hospice care for people with dementia. In this study by Giannazio et al., they looked at the effects of several policies, federal policies, on rates of disenrollment, among other outcomes. Before I had mentioned some of the federal policies that have been implemented in the last 10 years or so. And they found that disenrollment was already decreasing prior to these policy reforms, but is essentially plateaued after, and is still at a pretty high rate for people with dementia at about 18%. So our team is digging into these questions a little more by examining changes by reason for disenrollment, the impact of these federal policies. So I talked earlier about disenrollment for extended prognosis, which is the most common reason for disenrollment for people with dementia. But there is a number of other reasons that people can be disenrolled from hospice. They can revoke hospice because for any reason, but often because they want to pursue curative treatment. They can transfer hospices. They can, quote unquote, move out of a service area, but often this occurs because a person is admitted to a hospice or admitted to a hospital that the hospice does not have a contract with for providing inpatient care. In which case the patient is considered having moved out of the service area. And they can also be discharged for cause, which is when the environment is considered too unsafe for staff, but this is really quite rare. So these results are really preliminary, like literally I just got them yesterday, but we're seeing some interesting results where the rates of disenrollment, disenrollment for extended prognosis seem to be going down, and maybe there is an association with some of these policies that have been implemented. But we're also seeing increases in some of these other reasons for disenrollment, like moving or transfers to different hospices. So which raises concerns that patients might not be getting the adequate care that they need and are therefore choosing to transfer hospices or are having burdensome transitions to the hospital. So what are the key takeaways that I want to leave you all with today? So, end of life is a big deal in dementia. Dementia is highly prevalent at the end of life. People with dementia are having and their caregivers are having really difficult experiences during this time. The hospice population and market has changed a lot in the past 40 years since the Medicare hospice benefit began, including big increases in the dementia population in hospice. And because of features of the dementia trajectory and challenges with prognosis, and the hospice model really not being designed for people with dementia, we're seeing longer stays in hospice and more frequent disenrollment. We also see that there's a lot of variation and disparities in hospice care among people with dementia, but that overall hospice improves the end-of-life experiences for people and saves costs. We see that federal responses might be having some impacts on access to and quality of hospice care. All right, so what is the answer? Is hospice the answer? So people with dementia, in my opinion, benefit from hospice and should still be referred to hospice. But for those clinicians on the call, it's really important to think about hospice quality. So you can look at or refer patients to the Care Compare website, which has star ratings available for the hospices amongst other quality rating information. And this website is definitely not perfect, but it's what we have right now available. I would avoid hospices that don't have a quality rating available. And I think using word of mouth and your networks to learn more about what people's experiences is like within hospices before you refer a specific hospice. Also, for the clinicians in the call, I would say stay involved in your patient's care as much as you can after they're admitted to hospice. I think even a quick phone call to the families can make a difference to a patient and family not feeling abandoned. And especially for the less commonly occurring dementias like frontal temporal and Lewy body disease, there's much less understanding amongst hospice clinicians about how to manage symptoms in these patients. So if you're able to stay involved in their care and help advise on medications, et cetera, I think that would be very helpful. We need more research on how the hospice market changes and regulatory responses are impacting care for patients with dementia and hospice. And I think there really needs to be a lot more emphasis put on demonstration projects with both big and small changes to the Medicare hospice benefit. So there's a couple of projects going on right now looking at Medicare Advantage Carve-in, and the concurrent care project just wrapped up. But I think we need to be doing a lot of experimentation around different payment structures and tweaks to the benefit that could better adapt this model to people with dementia, while at the same time taking into account how bad actors might use the benefit to their own benefit. And then I would say we need much more investment in supports and services across the trajectory of care. So I think hospice is sometimes used as a substitution for supports and services that people need, but really we need a coordinated, large investment in understanding what the needs are and then providing them for this population. So with that, I would like to acknowledge my collaborators and mentors and colleagues, and of funding for this project. And thank you. I'm gonna escape out of here. And we have time for questions.
I have one, Lauren, actually. I didn't see, but that slide on the hotspot disenrollment, there was a really hot red one kind of in the south, and I was trying to figure out if that was Mississippi or where that was.
Oh, yeah. That's a good question. I'll have to go back and look. It's based on the hospital referral region. We use the Dartmouth Atlas. So, yeah, that's a great question. I'll have to go back and look at that.
Looks like from the chat, there was another question from Ellen. How can clinicians stay involved if they're not the hospice clinicians?
Yeah, that's a great question. So it is possible. So when people go into hospice, they are able to choose to stay as the primary provider, primary physician in care of that patient. That does mean that you will need to be available to the hospice staff and answering calls. And so I think, it's a lot of work as a provider, but patients can choose that, and providers are willing to offer that. I think there are benefits to having the hospice medical director take over as the primary provider, because they are in sync with that organization, and know their protocols, and are also very familiar with how to manage end of life symptoms, etc. So, but I think even if you're not staying on as the physician of that patient, primary physician, it's still possible to stay involved and just stay in touch with calls to the patient and family, and also staying in touch with the hospice clinicians. I think that many hospice clinicians, I worked as a hospice nurse, would welcome the opportunity to talk to a neurologist or other specialty care provider about what they think their patient needs. So yeah, that is a theme that is coming up again and again, and especially in qualitative research, is just how abandoned people feel, and not just in dementia. I think in other conditions, like I've heard about in heart failure, where they and oncology, where they just they feel really abandoned, and that relationship has been really important to them. So I think it would make a big difference in patients and families' lives to stay connected with them through the end.
So Lauren, thank you so much. What a great presentation. And I just want to follow up on what your comments here were. As a primary care geriatrician, I want to agree with you. I think geriatricians, because they're more primary care, although it's a subspecialty, many times do try really hard to follow our patients, because we're used to following people from setting to setting. And whereas we can't be, when they need hospice, we can't do that role. But I'm in agreement with you that the patients and family are looking to keep that engagement, because they feel like their primary care doc, either geriatricians or family medicine or internal medicine docs, know them well and have gone on this journey with them. And I think it is really hard if you've been followed by someone, say, for 10 years or something, and suddenly you're handed over to strangers at the end of your life. I think it is very challenging. So from the patient and family perspective, it's a good thing. And from, I think, many primary care docs, it's a good thing too, because you don't want to lose the connection with that patient. What I think has happened, though, I think the way practice has evolved lately, with the electronic charts and all the difficulties in multiple settings and so forth, I think it's gotten challenging for the primary care docs, whoever they are, to keep that close connection. And I think that's just, something you really have to work at to maintain.
Yeah, I mean, I think it's hard. It's hard for primary care providers and specialty providers because you're just so busy. It's really hard. So, I definitely understand, and there's not really space and time within our current setup to stay involved. It's basically going to be time outside of that you're not going to get paid for, but also really important to patients' families, and then thinking about what are kind of the structures that we need to help facilitate that.
Not sure what those are.
Yeah,
need
I mean, the
some
hospital, the model work in many ways. As a hospice nurse, I felt like it worked really nicely because everybody is working in concert within the hospice interdisciplinary team, and so then to have another outside provider is sometimes challenging because
Yes.
they don't know about the medications that you have on, but on the other hand, I think especially in the case of dementia and these more atypical dementias, I just think I look back and I think I didn't know what I didn't know at that time about how to manage those patients. So I think I would have really benefited from somebody spending just a little bit of time talking to me about what those patients needed.
Absolutely.
There's also a question in the chat from Eric Griffith, who asks, curious if you see opportunities to more regularly involve more family members or other social support in the hospice process. It seems like at least some of the isolation and difficulties in transition can be attributed to how many people in the United States are relatively isolated from the end of life process.
Mm-hmm. Yeah, I think that's a really important issue. We have a team of folks here at UCSF who are working a lot on isolation and living alone, on loneliness. And I'm really thinking a lot about how that impacts patients in hospice, because you are just seeing so many more patients who are really completely alone at the end of life, don't have anybody. So I think that's a really big challenge to think about how we better support those patients. I think in terms of the transitions in hospice, I think that the families, like transitions like disenrollment and being transferred to the hospital, I think we actually, I would look at it like we need to get more supports to families. They're struggling with this because they don't have enough supports, like financial support when they're taking time off of work, for example, or leaving the workforce, to be able to care for their loved one properly. So, or getting respite care, for example. So yes, I think it's important to involve family more, but I also feel like families are really, really stretched. So thinking about how we can spread resources around to make things easier for families and then potentially reduce transitions that way.
I guess I wonder about that. Do you think that an amount of that is sort of attributable just to sort of paperwork burden? And if so, if that's, a place where interventions could be helpful, in the sort of sense of like, patient navigation. Because I do think that the paperwork burden for stressed out families can be really difficult.
Yeah, no, the whole like applying for programs is a huge time burden for families, and I think it could be a lot easier. I'm actually involved in another project here at UCSF of the Care Ecosystem, which is a lay navigator program where patient with dementia and caregiver dyads are connected with an unlicensed but trained navigator who can help them navigate resources, a lot of these issues that are coming up for dementia, and figuring out the resources and helping them fill out some of that paperwork, hopefully. And that intervention has had really good outcomes in reducing caregiver burden and strain. So, and also it was the prototype for the new guide model. I'm not sure if any of you have heard about this. That was just a new project by Medicare to start basically a navigator program nationwide. So there's going to be some funding for that. So I think, yeah, more programs like that. And then also how to integrate those programs with end-of-life care, hospice care, palliative care is going to be a challenge going forward.
Well, we thank you so much for your time. I think we're toward the end of the hour here. You know, I didn't see any other questions in the chat that we didn't get to. Did I miss anything?
Nope.
And last
All right.
minute. Thank you so very much, Lauren. What a really wonderful presentation. And we appreciate the attendance of everyone and looking forward to seeing you next month as well. So wishing you all the best, and thanks so much for taking the time to present, Lauren, and to share your great work with us. We're really, it's really amazing work. Thank you so very much, and congratulations on your Beeson Award. For those who don't know, it's an extraordinary award that's very hard to get, and kudos to you. Outstanding.
Thank you. Thanks for the opportunity.